Well, everyone, I would next like to introduce Dr. Liz Bridges for our next NED Talk. As most of you know, Liz is our clinical nurse researcher here at UW Medical Center. The title of Liz's talk today is All In. Liz is an associate professor at the University of Washington School of Nursing and a clinical nurse researcher at the University of Washington Medical Center, Seattle. In addition, she is a retired colonel in the United States Air Force Reserve, where she served as the individual mobilization augmentee to the Director of Air Force Nursing Services. She has been instrumental in developing and supporting clinical inquiry at UW Medical Center since she joined the team in 2004. Join me in welcoming Liz Bridges.
Thank you. I thought I'd give it a try and actually give a TED Talk. I even looked it up. I even looked up what it was. So you know me. I did a little research.
We'd be disappointed if you didn't.
Oh, true. So what I wanted to talk to you about though is when you look at a TED Talk and they say talk about something you know. And what I know is 30 years in the Air Force, and what I know is 12 years here at UW-MC. And so I thought, talk about something I know. In 2009, I had probably the greatest opportunity of my entire nursing career. It was 26 years in the making. I was at the right place at the right time with the right skill set when a call came out that they were looking for the first director of the Deployed Combat Casualty Team for Afghanistan to stand up the Department of Defense's program. And so I said, yes, I want to go. And with the support of some great folks here at UW-MC and in the School of Nursing, I was able to go and to do that. And the only thing that I can tell you about this experience was, it was weird. There's very little else I can tell you to describe it. There are no other words to describe that. But one of the things that I had the opportunity to do while I was there as the researcher was my job was simply to observe, to watch what we did well, to watch what we needed to improve on, and particularly to look at areas where we could bring research to bear that would make a difference for our wounded warriors, and to do that in a quick way. The other thing that I did get to do while I was there, which was to my great passion, was to come back to the bedside in the ICU. And that was with the help of a very incredible preceptor who was very patient with me to help me to do that. But out of all of this weirdness, I started to see some things over and over and over again. And the first one was, what made this system so successful? Our healthcare system, trauma system, the outcomes from the military trauma system are as good or better than any in a level 1 trauma center here in the United States. And you have to remember that our hospital isn't just one place. It's 14 transfers, 8,000 miles, and 96 hours to bring our wounded warriors home. So how is it possible to have those really incredible outcomes? So these are just pictures from my days in Afghanistan, including the little flower and the rock, the unusual things that you saw. This is our board in the ICU. Gunshot wound to the abdomen, gunshot wound to the face, IED, gunshot wound, frag wounds. We got really good at taking care of those patients. And I will tell you that there's 3 more beds open and patients in the PACU. And that was our day, every day. But when I looked at all of this, and I still think back on this, the thing that struck me that probably is our greatest success is that everybody was all in. Everybody was fully committed to the mission that we had to do there. Our chaplain took it upon himself, when the traumas would come in, he would stand by the blanket warmer, so that when they were ready to have a blanket put on the patient, he moved to do that until he could get to the head of the bed and work with the patient. So now when your chaplain gets hypothermia prevention, I think you're all in. And I saw that time and time and time again. The other thing that I saw was so much extraordinary care and so much extraordinary heroism. Our wounded warriors, the first thing that they would always ask was not about themselves, but about their guys. And did they really have to leave? They didn't want to leave their guys. They were pissed off that we were going to have to send them home. And we saw that over and over and over again. The other thing that I saw was this incredible, extraordinary care by a team of people who came together from all over the military. We didn't, in many cases, know each other before, but who in very quick time were able to rapidly respond and come together to provide extraordinary care. We could have a mass casualty and in 45 minutes clear the trauma bay, providing extraordinary care as indicated by our outcomes. And you stopped and you looked at that, and what happened was you saw it over and over and over again, that it became very ordinary. And so the other thing that I saw there that I brought home with me was that when the extraordinary became ordinary. And so I think about, what does that look like? What does that look like for us? That was our hospital, Craig Joint Theater Hospital in Bagram, Afghanistan. I was also in Iraq, named after one of our medics who was killed in action. Those are the foothills of the Hindu Kush at 13,000 feet, or those are the Hindu Kush, they're the foothills of the Himalayas. We were about 30 miles from the Pakistani border, and we were the major trauma center for the eastern part of Afghanistan. And again, our outcomes were really pretty fascinating. And very early on in the war, Atul Gawande wrote a chapter in his book, Better, about why he thought the US military trauma system, why even early on in the war that it was so successful. And what he said was he thought it was three things. He thought first it was technical. It's the tourniquet, it's the blood products, it's the body armor. But then he said, you know, it really probably isn't that, because we've always had those. What was different was how we were using them, but the technology wasn't necessarily new. The second thing he said that was absolutely critical was a system that got it, a system that was all in. When we had a trauma patient come in, we were never surprised if they had a tourniquet on. As a matter of fact, we might have been asking, why didn't they have a tourniquet on? So from the field, the medics, the buddies, all understood that importance. So it was a system that was designed to do one thing and one thing only, and that was to provide world-class care to our wounded warriors. Now, the third thing, though, that he said he thought that was really the most important was really that vigilance over details. And that vigilance over details is asking again and again and again, how are we doing? What's the evidence behind what we're doing? And are we making a difference? And when you put all three of those things together, that was what was critical for developing this trauma system that was so effective. So in September of 2009, I came home with these new thoughts sort of in my mind. And I started to think about them, and I continue to think about them as we talk about how do we take our excellence to the next level. And when I look at these, though, I see those exact same attributes here at UW-MC. So when you think about the system, you say, well, what are the characteristics of a system that make it effective? It's ownership and leadership at every point of care, ownership and leadership at every level. It's about communication across the entire care continuum. It's breaking down those silos. And it's about having a vision. And if you really think about that, that's embodied in our attribute of professionalism. When I look at the technical, what does the evidence say about the best way to do something? The best way to use a piece of equipment, a new technology, a manner of care. And that vigilance over detail, that asking again and again and again, how are we doing? Are we making a difference? But also seeking new knowledge, the creation of new knowledge. And when you think about it, that's our culture of inquiry. Now, what I think is missing on Atul Gawande's is that he does not overtly recognize extraordinary care by an extraordinary team. And if you look at that, what I see there is our exemplary practice. So those things that made that US military healthcare system so successful already live here at UW-MC. We do those things every day. We just aren't overt necessarily about really always calling them out. So Aristotle said, "We are what we repeatedly do. Excellence is therefore not an act, but a habit." So how do we create those habits, or refine what we're already doing and create new habits to take our excellence to the next place? So recently I had the opportunity to give testimony to the Institute of Medicine on a panel that was exploring the success of the U.S. military trauma system. So I was brought on, I think I was the only nurse that they knew, so they called me up. But what they were interested in is that they said the reason they thought it was successful was that the U.S. military, that trauma system, really reflects what is now being called a continuously learning healthcare system. And what they were seeking to find out was, what were we doing that was right? What were the things that we needed to do to sustain that now that our operational tempo is down? How do we not lose those hard-earned lessons of the last 15 years? And what can we translate into our civilian healthcare system? So if you take a look at all of the characteristics that are integrated into a continuously learning healthcare system, I'm guessing you see our day. There's very little there that we aren't already talking about. And so what I'd like to suggest is maybe we think about this sort of a model and we take a step back and say, what are those things that we're already doing that are extraordinary? Where are those areas that, let's just look one more time and to say maybe that's something we need to really pursue to take our healthcare system forward. But I think we already have extraordinary examples, and so the question becomes, how do we become part of this conversation? We can learn from others, but I think we have a lot already to offer as well. For 30 years in the military, I lived by these core values: service before self, integrity in all we do, excellence. Those were the core values, and I could walk up to any airman at any time and say, what are our core values? And they could tell us that. It was our ethos. It was what we believed. The coin, the round circle, is the coin of the Air Force Nurse Corps, for all we serve. And we carried it in your pocket all the time. So it was always a part of who you were. So for 30 years that was my ethos. Now where I saw that come together and where those core values came together was in Afghanistan, where they all came together for the purpose of one mission and one mission only, and that was to bring our heroes safely home. The commitment to that mission was palpable. When we didn't succeed, everybody stopped and said, what happened? There was a commitment to that, to bring our heroes home. Now, I'm not sure that I could walk around UW-MC and say, what are our core values, that they would rattle them off that way. Now, I would just tell you that we had to memorize those in case somebody wanted to know what our core values were. At some point in time early in my career, somebody said, thou shalt memorize your core values, and you'll live by them. But I'll tell you what I see. A couple of years ago, we revised our mission statement. And we took it out for a test run. We took it to different groups of people and we said, what do you think about this? World-class healthcare by world-class nurses. And what I saw over and over and over again when we introduced this, first they go, ooh, can we really say that about ourselves? But then I saw a palpable sense of pride in who we already are and what we aspire to be. So how do we make that overt? How do we make that so that every one of our nurses understands that is our core value, that is where we're going? So I just have three sort of thought questions for us as we think about it. How do we make that an overt expectation? That everyone here, in whatever role they have, are contributing to that mission. That there's a place for everyone. How do we make that? In the military, we talk overtly about leadership. We talk about core values. It shows up in meetings. People aren't like, oh, we're talking about leadership? How do we make that a part of everything we do here? Is it in our job descriptions, in our new nursing care plan? Where do we make that so that it comes alive every day? It's not just some words on a flyer that we hand out once a year. How do we do that? How do we expand the conversation? These are pictures from the deployment, my deployment. And I would challenge you to tell me who's the nurse and who's the doctor and who's the respiratory therapist and the nutritionist and the social worker. And there are family members that are present there as well. In a system that to be successful, every voice has to have a place where they can be heard. That's critical. How do we do that? But Cindy, you've been talking about it now, so maybe now is our time to take a step back and look at our shared governance structures and not take away the places where we discuss what belongs to the profession of nursing, but to create places where now there is a habit of multidisciplinary interaction, and that we bring those together in our professional practice councils, in our local practice councils, in our unit councils, where that is interdisciplinary care as well. So maybe it's time to think about, how do we make that happen? How do we make that habit? Because I will guarantee you, I have doctors come to us to ask that the nurses lead the projects, because you guys know how to do this already. You already have it established, and so I think they can learn a lot from us as well. And then the third thing I think is engagement. How do we get everybody all in? What is that going to take to get everybody all in? So I like this quote. The real voyage of discovery consists not in seeking new landscapes, but in having new eyes. How do we look at things that we are already doing really very well and maybe just take a step back and go, ooh, what's the new thing? Where are different roles for leadership that we have not yet leveraged? Our new advanced practice nursing group, how do we leverage their expertise as well to make those things happen? So I think we need to just some thoughts on it. We are Daisy number 1. And it's something I think that we should be very, very proud of. But you guys may not be aware that UW-MC is a part of the DAISY program in the fact that some of the tenets that we believe here are parts of the tenets of their program. A few years ago, I was invited to help stand up the research program for the DAISY Foundation. And so one of the things that we created as a core tenet of the grant program was that the clinical nurses must be directly involved in the performance of the research, not only just to do that research, but to help them grow their skill set in research and evidence-based practice and in new knowledge generation. And we've turned away grants that have been very good because they did not include the clinical nurses. But that's what we see every day. Our nurses are empowered, our nurses are engaged. And so we made that a part of the DAISY Foundation's grant program, which is now international. So a piece of the UW-MC, when you look at that, that's where that came from. So I think we need to celebrate that. But how do we really make sure that our nurses are really fully engaged? How do we reach every one of them? When I go around and I talk about the Seattle Nursing Research Consortium, I just assume everybody knows what it is. Not true. We have nurses up on the floors in the clinics who, even though that program has been in place for 10 years now, have no idea what that is. Are there other things where we think we've got good engagement, but we haven't? So I think we need to really think about how to think about that as well. How do we leverage the extraordinary care and the extraordinary leadership of nurses who are already stepping forward, always stepping forward? Maybe it's time to bring a buddy to not only honor and recognize that extraordinary leadership, but maybe we mentor other people who maybe aren't as confident about stepping forward and really taking a step back and thinking about that. So it's not just the usual suspects. How do we get those other folks involved? Because what we want to do is we want to create a healthcare system that is responsive and hears the call of the Institute of Medicine, both in our terms of our own organization, creating this environment where nurses can hear that call to leadership to make a particular difference, but also that there is a professional expectation that you will respond to that call in whatever capacity you have. In whatever capacity you have. How do we make that happen? How do we get all of our nurses all in? I think the last thing that we want to do is we need to remind our nurses and make sure they're aware of how important they are. This is in southern Afghanistan, just when the dust would blow in. One of my colleagues, Dr. Zolt Stockinger, a Navy trauma surgeon, was in southern Afghanistan the same time I was deployed. And he wrote a very eloquent piece that was published in the journal, in JAMA. And I would like you to think about us when you hear these words, because, again, what I say in the military, I hear and I see here. And the question is, how do we get that? So another Marine comes in receiving CPR, multiple IED fragments to the neck and leg. The neck is a bloody mess. Bilateral neck explorations are done. The lacerated external carotid is ligated. Fragments and rocks are removed. While we're doing this, our trio of gas passers have given the man 45 units of blood and blood products, filling the tank for the hour it took for the surgeons to plug the holes. But we're caught up, and the man's alive. He's flown out by helicopter, still being resuscitated, but he makes it to the next rung up the long ladder. There we learn he receives another 100 units for his coagulopathy. But he lives. And on to the next stop, and the next, and finally, hopefully home alive, home to his family. He is our 1%er, that small fraction of trauma patients receiving CPR who survive. By all rights, he should have died, and probably would have died even at the best level 1 trauma center in the United States. He is the justification for why we do what we do. We pull out all the stops for them, as we do in every war, because we have to. We do it for them, we do it for their comrades, we do it for ourselves. Because when these young men and women go outside the wire, they need to know that we will be there for them. There is no feudal care here. He and his family do not know our names, nor do they need to. We are just a few of the hundreds of people who make up the links in the several thousand-mile-long chain of medical care for our wounded warriors. If one link breaks, it all fails. It's a team sport. How do we make that a reality here? How do we get everybody all in? That's the indelible lesson that I learned. But the last thing I learned, again, is that every once in a while, we need to just stop and take a look around. The things that we think are ordinary are really quite extraordinary. So thank you. Happy Nurses Week.